It's January 15th, 2011. Carol and her mom and my lovely wife just came back from a terrific ski trip, and now we're having a relaxed day on Saturday before Carol goes back to Bedminster.
One of the things that came up when we were talking about Dad's professional history was the question of why hematology? How did he end up in hematology? So we thought we'd record that here. So why hematology?
Well, that's a long and torturous story. I'll try to be reasonably brief. So back to how and why I went into hematology. Well, it really starts with my childhood, and through high school I used to build model airplanes, lots of model airplanes, probably build 5 or 6 dozen of them. And I built them out of balsa, light wood, and tissue paper. And I was pretty compulsive about my airplanes. They were, when the covering of the wings or any surface was made, if there was any even slight crease in it, I would redo it till it was perfect. And even things that were covered by tissue paper, if they were gluing inside, like the ribs of wings, I would cut out with a razor blade any excess glue. So this was a hobby of mine lasting throughout high school, and even built a couple of models after that, some of which I still have. But it showed that I had quite good dexterity with my fingers, and I liked that part. I didn't do any model building during college. College at Berkeley, I majored in physics and chemistry, but by the end of the second year, I couldn't decide what I wanted to do with either physics or chemistry. So my brother, having gone off to medical school or applied to medical school, suggested, why don't I think about going to medical school? And I thought that was a pretty good idea, because that would delay my having to make a decision of a career by at least 4 years, which I did. I had good grades in college, so after my third year, I applied and had no trouble being accepted. In the first year of medical school, in the anatomy class, where we did dissection of a cadaver, I found myself again quite skillful at the dissection, and received several compliments from the prosector or the faculty member that my dissections were really quite good. In the third year of medical school, we took surgery, and during one of my first operations, which was a dog splenectomy, which took 3 or 4 hours, I found that my feet hurt. And I said, well, gee, I really liked surgery, but this isn't going to work. So then I decided that surgery was out, but hadn't given it up totally. And in my 4th year of medical school, I took a course in surgical anatomy, simply to learn what kind of approaches there are to operations, because I figured I wouldn't be exposed to that anymore in any part of my subsequent career. But I thought of one thing in terms of surgery, and that was ophthalmology. Because in ophthalmology, you can sit down while you're doing surgery. So that was in the back of my mind, but I decided that I'd better take an internal medicine internship, which I did at the Boston City Hospital. After the year in Boston, we went to San Francisco, and I went to the Stanford for my residency. The Stanford University Hospital was then still in San Francisco. And as a resident, I had some extra time to do what I thought would be fun, to do some research. Residents are not as busy as interns. And so I looked around for a laboratory that might give me a desk and a small bench. And Dr. William Krieger, who was head of hematology, said, fine, you can have a desk, a little bit of desk. And so that's when I was introduced to hematology. Well, I did a few experiments there, and also it led to the first paper I wrote with colleagues. By the way, I went to Stanford partly because Dr. Victor Richards, a neighbor of ours, was the chief of surgery, a good friend and one who wrote letters for me for medical school application. I also found that he was a superb teacher. I would round with him at 7 o'clock and medical rounds at 8 o'clock. But the beauty of the surgical rounds was that these usually were preoperative, and there you would learn within a couple of days how good you were about diagnoses. So that was good. And working with his department, there was a patient who bled, but who needed kidney dialysis. And so you couldn't heparinize them because they would bleed. So along with my colleagues, we devised a way of regional heparinization by only making the blood incoagulable as it goes into the kidney and the artificial kidney, and neutralizing it when it came out. So the blood going to the patient would be normal and the patient wouldn't bleed. And that led to the first publication, my first publication, in the New England Journal around 1956, I think. At any rate, the draft was still on, particularly for doctors. So I applied to the NIH and went there for several interviews and was accepted in the Institute of Arthritis and Metabolic Diseases. Dr. Joseph Bunham, a wonderful internist, was the head of the service. And I told him that I was particularly interested in continuing some work on hematology or red blood cells, and he said, fine, we have such a unit in our department. And I started that for about 4 weeks, but then there was a change in staff, and he said, I'm sorry, you can't continue the work in hematology. I need you to help out on drug screening for rheumatoid arthritis, and they were screening new drugs, particularly analogs of cortisone. These came to an abrupt halt when someone else found prednisone, which was 5 times as effective as cortisone and not as and much more effective than drugs that we were testing. At any rate, I continued my interest in hematology, and clinical associates, which was the title of the position I had, were expected to give grand rounds or other talks on subjects of their own choice every 6 or 8 weeks or so. So the topics I chose happened to be in the hematologic area. One of them had to do with the anemia of rheumatoid arthritis. Another one, more interesting, it had just been discovered that there was an enzymatic defect in red blood cells. It affected the enzyme Glucose-6-Phosphate Dehydrogenase, short-term G6PD, which turned out to be of great interest to me for the following reason. The red blood cell, up till early 20th century, was considered a corpuscle, namely a dead cell. It wasn't perceived to be a living cell. It had no nucleus. It didn't divide. But it was found that instead of being just a bag containing hemoglobin, it was really a sleeping giant, bristling with metabolic activity. But interestingly enough, although it is the major cell and has the greatest concentration of oxygen of any cell in the body, its metabolism is anaerobic and functions totally without oxygen. And the only other cell in the body that does that is the lens. And, but I knew that there was this anaerobic pathway, glycolytic pathway. It goes from glucose to lactic acid, but it has two little offshoots. One that's called the hexose monophosphate shunt. The other one is called the Rappaport-Lubering pathway. But that's the major pathways of metabolism in the red cell. Well, as I mentioned in one of the other tapes, I had become interested in carbohydrate metabolism, particularly because it applied to the red blood cell. And this enzyme defect that was discovered in 1956, and the time for me at NIH was from 56 to 1959. So it seemed to me that this enzyme was the first enzyme in one of the site pathways, the hexose monophosphate shunt. And the reason this was worked on is that patients had been discovered, black African Americans who had served in Korea had been given the drug Primaquine, an anti-malarial drug, and destroyed their red cells. And it turned out that about 10% of black Americans reacted to Primaquine in this fashion. And so this became intensely interesting for studies. One of the three geniuses in my life that I met was Ernie Boiler, who, and as a quick aside, because Ernie Boiler is one of those geniuses who is modest. He was born in Berlin, came over with his family in 1913, graduated from the University of Chicago at 17, and their medical school at 21. And he worked on a variety of things related to, he was able to work in the Joliet prison in Illinois, and had volunteers, and he published a variety of studies as what was abnormal in these cells, how the red blood cells of these individuals behave differently. He did not actually discover the enzyme defect, but his studies from 1951 to 1956 led to Dr. Carlson discovering this enzyme defect. So this enzyme defect is the first step in a pathway that the red cell is important for the red cell membrane maintenance, and I won't go into that. But I figured that there ought to be an easy test that I could use. It was known how that pathway could be stimulated. As I mentioned, there were ways that glucose, which is the starting point for the energy requirements of the red cell can go in a main pathway and two side pathways. And when it was known how to stimulate the direction of the glucose into one or another of these pathways. And as I mentioned, the first enzyme in the pathway, the hexose monophosphate shunt, was the one that was shown to be defective in these black Americans who responded with red cell destruction when given a drug. I figured that having now learned a little carbohydrate chemistry, that if you take glucose and label it with a radioactive carbon, carbon-14, but label only the first of the 6 sugars of the glucose molecule, it's the first sugar that comes off in the hexose monophosphate shunt. So if you incubate red blood cells with radioactive glucose labeled only in the first position, and then stimulate the cell with methylene blue, which simulates that pathway, anyone who had a defect in that pathway would produce less carbon dioxide would have less labeled carbon dioxide than a normal person. And that turned out to be true. And so actually there was a metabolic test for these defective red cells. And that excited me. That I knew that there were families of patients who had early destruction of their red cells. And I surmised that some of these might be due to metabolic or defects in their metabolic machinery in one or more of these enzymatic steps, in one or more of these 3 branches of the pathway. And that really excited me about furthering studies in hematology, and so I looked for hematology programs that focused on red cell destruction, and this one happened to be in red cell storage. And so I learned that Dr. Finch had a program in studying stored blood, but they were not studying very much of the metabolism of glucose. And so I applied there for my fellowship and got it, and that led to my commitment, if you will, to hematology. So that was the... Now there's another wrinkle. There are 2 wrinkles I want to talk about. One was in 1958, while I was still at NIH, I met the director of the physiotherapy program, or physical medicine program at NIH, and we got into a casual conversation that my feet hurt when I stood. And he said, "Oh, well, what you really need is a 1/4 of an inch wedge in the inner aspect of the sole." And he said, "You go to France Ritchie down in Washington, D.C., and get those shoes with that particular last and try them on." Well, I never had more standing difficulty after that. And had I known about that wedge in medical school, I would have been a surgeon. Now, and it turned out these shoes, the first pair, cost $19. And every 5 or 10 years or so, I'd buy another pair. Once we moved out of Bethesda to San Francisco, then back to Bethesda, then to San Francisco, Albuquerque, Bethesda, back to Phoenix, I always bought by mail or personally another pair of these identical shoes. They were 9B, and they had this last, and one pair black and one pair brown. And those are the only shoes I wore from age 27 to age 78. The last pair I bought cost $102. So that really was how fate, in a sense, this time it was a 1/4-inch wedge in shoes, determines careers
Wow.
in some way. I do want to say something about glucose-6-phosphate dehydrogenase, because this discovery of that this enzyme defect was present in blacks led to many other studies. And it turns out that over the next 2 decades, at least, I would say, 5 dozen different enzymatic defects of this single enzyme were discovered. They all affected the enzyme, but they affected the metabolism in different ways. Some people had the enzyme were not sensitive to drugs. Some were sensitive, but moderately sensitive. Others were extremely sensitive. And then there were some that destroyed their red cells early. Same enzyme affected, but in a different way. And they had chronic destruction. And I studied a number of such families and looked for other enzymatic defects, found some, many other workers found many more, so that there are now actually known defects of each of the almost every enzymatic step. But there's something very interesting about this particular one, G6PD. It's the most prevalent of all the enzymatic defects. And it affects the common varieties are seen in people who, black Americans and blacks from Africa. The second most prevalent group is in Sephardic Jews. The third most prevalent is in the Mediterranean littoral, at southern Italy and around Tunisia and Morocco and so forth. And what all of these areas have in common is malaria. And like sickle cell disease, people who carry this enzymatic defect, their children are less susceptible to severe cerebral malaria. And the reason for that is that the malarial parasite spends part of its lifespan in the red blood cell. And with this enzymatic defect, it's a less favorable environment for the malarial parasite. And so this provides a survival advantage in a malarial region. Now there's one form of this enzymatic defect which is even more fascinating, and it leads to a particular enzymatic defect in southern Italy and in Greece. And a disease long known, at least described in the 19th and 20th century, is called favism. It's that people who eat the fava bean become terribly sick, sometimes die, and they destroy their red cells. Now, it turns out that people who have favism, or their parents, or this happens to be an X-linked defect, so it affects males, and women are carriers. And women are rarely affected for reasons that I won't go into. But the interesting thing about that is that, first of all, there's something in the fava bean that's necessary for this destruction to occur. And 4th century BC Greece, there was a bean cult, and Pythagoras belonged to this bean cult. In fact, Pythagoras insisted that any of his disciples must also refrain not only from eating the fava or the broad bean, but have to stay away from fields, particularly in the spring when the fava beans are harvested. And it is said that when the Romans chased him, they chased him to a field of beans, and rather than him entering the field, he was killed at the edge of a bean field. But that was 2,000 or more years ago, but the bean cult persisted for some centuries. And I have a rare reprint dealing with a bean cult. It's actually called Pythagoras and the Beans. And it took to 1956 or beyond to find out what makes this particular enzymatic defect susceptible to the fava bean. But other people who have the defect are also urged not to eat the broad bean, and particularly in the spring, go through bean fields. And there's a wide variety of drugs which are contraindicated in people who have this enzymatic defect. A fascinating story in my point of view. Enough of why I went into hematology. But there was this clue then. It allowed me to do some, using the carbohydrate metabolism I learned at NIH, applying it to a number of families that were referred to me in Seattle. And it was a privilege to study entire families. It was a time that you had the time. I could interview each member of the family, and as I may have mentioned to some of you, in one particular family, the Anderson family, it was a family of 4 sisters, all of whom were beautiful. And you could tell from the clothes they wore which of them was affected by an enzymatic by a defect in their red cells, because the ones that were affected had a slight tinge of yellow, of jaundice in their skin and in their sclera. And they were very sophisticated, and they chose clothes that were appropriate to their coloration. And the 2 sisters that were not affected wore different clothes. And that was the time of when hematology was fun, when you could spend as much time as necessary studying the family, learning them, and becoming closely involved with them. Thank you.